Hello everyone, in this lecture we'll be discussing hyponatremia. Let's get started. If we have a patient that has a low serum sodium, less than 135, to determine the cause of the low serum sodium, we're going to next check the serum osmolality. When we check the serum osmolality, and if the patient has a normal serum osmolality, then the cause of their low serum sodium is going to be due to either high levels of triglycerides or high levels of proteins in the serum. We also call this pseudohyponatremia or fake hyponatremia. And the reason for this is because if the patient has high levels of triglycerides or high levels of proteins within their serum, these two particles can then displace the sodium within the serum, causing the blood analyzer to falsely think that the patient has low serum sodium when in reality they have a normal serum sodium. So this is why this condition is called pseudohyponatremia or fake hyponatremia. If the patient has a high serum osmolality, the most likely cause of their low serum sodium reading is going to be due to hyperglycemia. Remember that glucose, imagine that these red dots are glucose molecules. When we have high levels of glucose within the serum, they're then going to go into the kidneys and be filtered out into the urine. And if we have high levels of glucose within the urine, it is then going to draw out large amounts of water into that urine. So we're going to be losing a lot of fluid. And if we lose a lot of fluid, this is then going to concentrate our blood. And so that is why we're going to have high serum osmolality, because the blood is going to be concentrated because we've lost large amounts of fluid because the glucose has drawn out the water from the body. Now let's discuss what we're going to do if the patient has a low serum osmolality. And this is going to be the most common cause of hyponatremia. The next step we're going to do if the serum osmolality is low is to check the fluid status of the patient. When we check the fluid status of the patient and the patient is hypervolemic or they're fluid overloaded, to determine the cause of their hypervolemic hyponatremia, we're then going to check their urine sodium. If the urine sodium is greater than 20, then that means that the kidneys are not doing its job. Remember, the job of the kidney is to the job of the kidneys is to make sure that we have a normal electrolyte balance within the body. And so if we have hyponatremia or low serum sodium, then the kidneys should reabsorb water, or excuse me, the kidneys should reabsorb sodium back into the body, and we shouldn't be losing sodium in the urine. And so if we're losing sodium in the urine when we have low sodium levels within the body, that means that the kidneys are not doing its job. And so that means that the cause of their hypervolemic hyponatremia, if we have a urine sodium greater than 20, is renal failure, because the kidneys are not doing its job of retaining sodium when our body is depleted in sodium. And so to treat this patient, we're going to dialyze them, and we're also going to fluid and sodium restrict them. Now, if the urine sodium is less than 20, the cause of the hypervolemic hyponatremia is going to be due to either heart failure, cirrhosis, or nephrosis. And to treat these patients, we're going to diurese them to get rid of that extra fluid, and we're also going to fluid and sodium restrict them. Now, if the patient is euvolemic, then next we're going to check their urine osmolality to see if their urine is concentrated or not. If the urine osmolality is greater than 100, this tells us that the most likely cause of their euvolemic hyponatremia is SIADH. So imagine that imagine that this is the urine that's being filtered out by the kidneys. So the job of the antidiuretic hormone is to reabsorb water. So we're going to reabsorb water that would normally be lost in the urine back into the body with the antidiuretic hormone. And so what this is going to do is it is going to concentrate the urine. So the urine osmolality is going to be greater than 100. Remember, the antidiuretic hormone only reabsorbs water through the aquaporin channels. We're not reabsorbing anything else. So that is why we're going to get hyponatremia, because that extra fluid that we are reabsorbing is going to dilute the sodium within the serum. Other causes of euvolemic hyponatremia when the urine osmolality is greater than 100 can include hypothyroidism, adrenal insufficiency, stress, and drug use. Now, if the urine osmolality is less than 100, that means that the patient is consuming too much fluid, diluting the sodium within the serum, as well as diluting uh, the urine. So the cause is going to be primary polydipsia or beer proteinemia. And The treatment for both of euvolemic hyponatremia is going to be to fluid restrict the patient. Now, if the patient has hypovolemic hyponatremia, we're going to check their urine sodium again. And if the urine sodium is less than 20, that means that the kidneys are doing its job of reabsorbing the sodium when we have low levels of sodium within the body. So that means that the cause is going to be extrarenal salt loss. So this can occur with diarrhea and vomiting, burns, third space losses, as well as bleeding. And we're going to give back fluids and sodium back to the patient with isotonic saline. Now, if the urine sodium is greater than 20, that means something with the kidneys is happening. And so the patient most likely is taking a diuretic, hindering the ability of the kidney to reabsorb sodium and water, or it could be due to primary adrenal insufficiency. Remember that the adrenal gland is responsible for producing aldosterone, and if the adrenal gland is not working correctly, then the aldosterone is not going to be produced. And the function of aldosterone is to reabsorb sodium and water. And so if we have low levels of aldosterone, then we're going to be losing sodium as well as water. And to replace the sodium in the water, again, we're going to give the patient isotonic saline. So the treatments that we discuss are going to be used when the patient is asymptomatic. If the patient is symptomatic, then we're going to give them hypertonic saline, and we're also going to bolus them with 100 milliliters of fluid. And the goal is going to be to increase their sodium by 4 to 6 over a few hours. Now, if the patient has acute hyponatremia, meaning that they had the low serum sodium readings less than 48 hours, then we can correct their sodium levels as fast as we would like because their body has not adapted to the hyponatremic state. But if they have chronic hyponatremia, then we need to be very careful and we need to correct their sodium by 6 to 8 over a period of 24 hours to make sure that we don't hurt the patient. We can cause osmotic demyelination syndrome if we correct their sodium too fast.